And now before that we were discussing mostly the transverse or oblique fractures which have not been comminuted. But with the advent of cars and high-speeding cars, you really know the trauma is a high-energy trauma for most of the time, and it may be associated with comminuted intra-articular fractures. In this section, we'll be briefly discussing this entity, that is distal radius fractures, which are highly comminuted. We'll be discussing the fragmented intra-articular fractures in young adults, their treatment, and complication of distal radius fractures, especially if they're highly comminuted. Now, intra-articular fracture in adults usually involve either the volar or the dorsal lip at the end of the bone, but that is when they're not comminuted. Sometimes they can be comminuted as well. Usually associated with high frequency post-traumatic arthritis. Why? Because this distal radial joint is unconstructible or it is not properly reconstructible due to comminution. Usually high energy trauma, its usually poor outcome is always associated because of comminution. Anatomical perfection is not essential and sometimes even cannot be achieved as well. And usually the posterior anterior lateral x-rays are taken, and oblique views may also be required, especially the CT as well, so we can know what is the degree of comminution and how much we can salvage the joint. Sometimes instead of really applying any kind of internal fixation, the comminution is so much that we have to just apply a distraction fixator and allow the fragments to heal in the malgenerated manner. Treatment could be a simple manipulation and anesthesia and cast, but that is only if it is a transverse or oblique fracture with whether intra-articular or extra-articular and there is no comminution. With x-rays are done needed at about 7 days, and sometimes when the comminution is reduced under GA, we can still go for a plaster, but we have to get a repeat x-ray 7 to 10 days just to see whether any of the fragment has got displaced or not. If the fracture is undisplaced and at 14 days, we can continue this cast for a longer period of time, but if we cannot, we may have to go for either the closed reduction internal fixation with K wires or probably open reduction internal fixation of the fracture fragment. Other options is if they're dorsally displaced, we can go for dorsal plating or open reduction internal fixation with the dorsal plate. If the fracture fragments are volarly displaced, we can go for open reduction internal fixation with the volar plate. All fragments are reduced in good position. Volar or dorsal interlocking plates are mainly used, and they can be once they're applied. Then special implants are also available now, like if you see this kind of screws are available in which basically all the fragments which have been actually incarcerated into the joint are removed and kind of articulating surface is actually created. But usually sometimes the best option is just to apply a distraction fix to allow the wrist joint to expand so that the intra-articular comminution is reduced and there is no intra-articular step, and later on we can treat other things. Okay, now with degree of comminution and high energy trauma, there is always associated complications, and when we even with aggressive treatment, they can still have complications. Early complications include circulatory problems. It could be a neurovascular damage at the time of injury, which could be problematic later on, or in form of a nerve injury as the median nerve, ulnar nerve are passing through this. Even the distal radial nerve, part of the radial nerve is actually passing just through the snuff box. This could be associated, even if we have done the volar or dorsal plating, this could be still be associated with complex regional pain syndrome. The patients may have complaints of pain, paresthesias, and altered sensations, and especially unable to move his or her wrist joint properly. There could be ulnar corner pain and instability, and there could be some kind of degree of impingement as well, or ulnar abutment syndrome could be present as well, which could be very damaging, and patient may complain of the pain on the ulnar side of the wrist joint. Although there was a comminuted distal radius fracture, there could be associated injury of the carpal as well. There could be radiocarpal instability, or there could be a mid-carpal instability later on. Why? Because there could be associated the intercarpal ligaments or radiocarpal ligaments may have disrupted at the time of injury, and this now may be producing the instability at the wrist joint. Or there could be redisplacement, that once you get a x-ray at 10 to 14 days, what you see is despite having a plate, one of the fragment has gone intra-articularly and actually causing an intra-articular step, and which could be later on leading to arthritis most of the time. Now, what are the late complications? The late complications include the malunion. There may be associated pain and deformity of the wrist joint. The patient may not be able to use the wrist joint properly, and you get the X-rays, you results in a malunion because the fracture is united in a position which is not in an anatomical position. And what was the anatomical position? That was that at least the radial height should be 8 mm or 6 to 8 mm in some books, and we should have at least less than 20 degrees of volar tilt, and we should have less than 10 to 15 degrees of dorsal tilt, and there should be no articular step. If it's not in this criteria, this is probably a malunited fracture. This could be even a delayed union or even a non-union, that despite applying an internal fixator in form of a dorsal or volar plate, distal radius may be going into a non-union. Other problems which usually appear late is because, especially with these abrasion effect of the tendons over these plates, this can actually result in tendon rupture. Especially with the volar plate, there could be damage to the FPL, or with the dorsal plate, there could be damage to the EPL. There could be carpal instability. Why? Because there could be problems with the ligaments at the time of injury as well, or even with over the period of time they may disrupt or get disused as well, and this results to radiocarpal or mid-carpal instability. And other problems could be the secondary osteoarthritis, which is called as post-traumatic osteoarthritis at the wrist joint. In this section, we have briefly gone through what are the comminuted distal radius fractures. Usually they're in the young adults and associated with a very high energy trauma, and as there is a lot of comminution, sometimes the joint is really constructible. Most of the time we have to go for open reduction, but sometimes when the closed reduction is done and we view the x-rays, we can go for closed reduction and simple plaster or use of closed reduction internal fixation with KYs. But most of the time we have to go for open reduction internal fixation in form of either the volar plating or in form of dorsal plating. As it's already a high energy trauma with associated comminuted fractures, and even that itself has problems and complications, but we have to go for surgery. The surgery may also manifest other associated problems as well, which could be early or late complication, could be neurovascular damage, could be malunited, non-united fractures, could be complex regional pain syndrome, could be mid-carpal, radiocarpal instability as well. Thank you very much. Keep watching sqadia.com.